Hey guys, it cuts me off apparently if I go too far past 30 minutes, so I'll try to finish this up quickly, but I was on abdominal procedures before my phone cut me off. So on abdominal procedures, let's talk about suction lipectomy, which like I said is liposuction. Yes, you will do this in the operating room, but I included a slide on fat grafting instead. That's because it's the same idea as liposuction, except instead of sucking that fat away, we're going to keep that fat in a syringe. So typically for breast cases, so a lot of these plastic surgeons do these things together, right? Liposuction and breast implants. So what they started doing is using that fat instead. Why would you throw that fat away when you can inject it into the breast tissue? Most of the surgeons I worked with called it liquid gold because it makes it look more fuller and natural if you inject that breast tissue with your own fat. So, of course, the patients love that. Well, while we're in there, would you like us to take some fat off of your abdominal area? Of course I would. So they usually take it from the front or sometimes on your back. They can get it from either side laterally, but pretty much whatever the patient wants. So I included a slide on tulip cannulas, is what they're called. And I really like these cases because you get to play with the fat. So I know it sounds silly, but you are injecting with that tumescent solution that it talks about in your book to loosen everything up. So first of all, let's talk about that. So your tumescent solution, it goes through what's in it on page 794. So you still need to study this section on liposuction. But again, it's going to go hand in hand with the slide I put on there about tulip cannulas. So same thing, but we're keeping the fat instead of letting it get sucked away. So your tumescent, it's got lidocaine, epinephrine, and white So lidocaine for pain, of course post-op and during the case, because if we can keep our patients awake, we like to keep them awake and not put them under general anesthesia. But that's an option on this case, so it's up to the surgeon. The white if you don't remember what that is, I know it's from surgical pharmacology, so I will remind you. So it's going to enhance the other drugs. So it's going to enhance the absorption, especially, of those drugs. So it's going to allow that epinephrine to absorb faster, so there's less bleeding throughout the case. So it causes that vasoconstriction that we want, so there's less bleeding throughout the case, and then less pain with the lidocaine for the patient. So that's why you're going to have that mix. You're going to have this exact same mix with the fat cannula grafting as the liposuction. But I'll get to the part that I like. So they inject with tumescent, they do the liposuction and pull the fat out in a syringe. I posted a video on YouTube so you can see what the fat looks like. You will see them inject it over a lap and kind of strain it a little bit. We had an actual strainer, like a strainer you would have in your kitchen for your pasta. We had a strainer like that because we wanted to separate the fat from the blood. So if I handed my surgeon a syringe and it was even slightly pink, he would not accept it. He would say, you didn't wash this well enough. I want that liquid gold. So you're going to want to filter that fat really well because we don't want to inject more blood back into the patient. That's not helping fill in that tissue. They want it to be 100% fat. So in whatever form your hospital gives you, you will strain that fat, present your surgeon with the liquid gold so that they can inject it and make that breast implant look more full and more natural, because sometimes you can actually see the lines on some patients, or you can tell that they're implants. And this basically, well, it uses your abdominal fat for another use to increase the breast size, but more than that, it just looks more natural and full. So that's why our patients like it. So when you're looking at that slide about fat grafting cannulas, look over your liposuction in your book. Okay, your next one on page 795. So this one is an abdominoplasty. So if it is large enough that it's considered a pannus, so if it's large and lying low enough that's considered a pannus, it'll be a paniculectomy. So you do need to know that term, even though it talks about abdominoplasty in your book. I need you to know both terms. So abdominoplasty and paniculectomy. So basically the same idea. We're cutting off any extra tissue that is hanging over, especially if it's a pannus. So you're going to need those lighted retractors again to see into deep cavities. They typically have a scale in the room also because the tissue that they cut off, they want to weigh it so then they can go back to the patient and tell them, hey, we took 10 pounds off of you today, or whatever the amount is. So you want to have a scale in the room. I think that's one thing that's not on here. Abdominal binder for the end is going to be your dressing. So this is going to keep it all enclosed so that they don't rip open those stitches or have any damage happening to their abdominal incision. As far as the procedure goes, I'm not going to go through the whole thing, but it's a low transverse incision. You need to know that. Looking at number 4, so it talks about making a second incision around the umbilicus with that cookie cutter. So again, in your instrumentation book, page 163, it's got the cookie cutters, and those are the templates for the nipple cases where you're reconstructing a nipple. But they can also use it to cut out where they're going to put that belly button. So hard to explain, so I put a good picture. I believe it's the last picture in your slideshow. So you can see how they have all the skin pulled up and the belly button is sitting there preserved. So there's lots of different ways to do that, but the idea when they're doing this case is one of their main focuses is getting that belly button back in the right anatomical position. Because if we cut out all that extra fat and then we put it back down and the belly button is way low, they're not going to be happy with that. They're there for a plastic surgery, so they're there to look better. So we don't want to make more defects while we're in there. So number 4, make sure you know they can use that cookie cutter to prepare for that umbilicus, to not have that too low for the abdominoplasty. You'll see the term paniculectomy on page 797. So you can see how to spell that one, but again, if it's a full panis that's laying down, that's when they're going to call it a paniculectomy. So looking at number 6 on that page, 797, you're going to see that when they raise that flap of skin up, you're going to see the rectus abdominis muscle, so you need to know that anatomy. You should add in the word tighten on top of that. The whole point of pulling this down and revealing the rectus abdominis muscle is to tighten it. So it's bringing everything closer and tighter together. So the muscle along with the fascia is pulled together and sutured from the abdominal wall. So at the end of these cases, typically they're going to have a long incision, but they're plastic surgeons. So they're going to close it very well so that they're not going to have much of a scar. So it's still a plastic surgery for them. So a lot of plastic cases, they're going to take a lot longer to close. So as you're doing your externship, hopefully one day soon, you will see the difference between the way a plastic surgeon is going to close an incision versus the way maybe an orthopedic surgeon would close an incision. And they could be working on the same area. So orthopedic surgeon could use a little nylon and just do a couple interrupted stitches and leave it and say it's good. The plastic surgeon might get a Prolene or a monocryl and sit there and meticulously do a beautiful running stitch so that it looks fantastic when they're done because they're plastic surgeons. So as you're reading through this, try to note the difference between this specialty and other specialties. Again, if you have any questions, put them underneath. Like I said before, as far as your participation, I just wanted you to comment something. So if you can't come up with a question, comment anything, ask me how I'm doing, anything. Tell me about the weather. Tell me how you're doing practicing your lab skills at home. Just keep me updated on what's going on. I made myself one more note. As I was going through some of your Mind Tap answers, I found some interesting things. So I think there's a little bit of confusion on bipolar and Bovie. Luckily, when I left the school for the last time on Friday, I grabbed as much stuff as I could because I knew I might need some things for lecture. So ironically, I have the exact 2 things that I need. So just a reminder for you guys, this is your Bovie, correct? You all know this because you use it in lab all the time. What we're forgetting are the alternate terms. So monopolar, Bovie. Monopolar, 1, right? Bipolar has 2 prongs. So bipolar is what we're going to be using a lot in these plastic surgeries, really in all the specialties we've recently talked about. So ENT, anything on the head and neck, so plastic surgery, they're going to try to use bipolar. So the idea is we don't want to leave a char line with this Bovie. If we can, especially if we're on internal structures, if we see a vessel, we can just wrap this around and bipolar it off. So as you're reading through the book, try to pay attention to the equipment. If it says bipolar versus Bovie, try to notice why we have bipolar versus Bovie. Some of these, they're going to use the Bovie to dissect down in the beginning, but those bleeders internally, they're only going to coagulate those with the bipolar because of where they are. Think about if you're deep in the neck or deep in the breast tissue, you couldn't reach a Bovie down there if you wanted to anyways, but this because of the bayoneted, you can reach down deeper and coagulate those vessels. So again, I wanted to go over the difference between a Bovie and a bipolar. So if you guys have any other questions, of course, let me know. But again, your participation grade as far as that goes is just any simple comment on anything on the post, on any of the posts on the page every week. So as long as you say something to me every week, then we're good. I will consider that your participation. Again, if you have any other questions, comments, let me know. I'll talk to you guys soon. Have a good one.